Introduction. Glaucoma is a progressive eye disease where the optic nerve at the back of the eye is damaged, leading to vision loss. Because glaucoma often causes no symptoms until later, doctors use various tests to spot it early and track it. One key tool is Optical Coherence Tomography, OCT. OCT is a non-invasive imaging scan that uses light to make cross-section pictures of the retina, the light-sensing layer of the eye. It can measure the thickness of important retinal layers and the optic nerve head. By tracking these measurements over time, OCT helps doctors see damage to nerve fibers before it shows up on vision tests. However, OCT is not perfect or standalone. It's one piece of the puzzle in glaucoma care. What OCT measures and how to read it. OCT produces detailed images of the retina, which doctors interpret in simple ways. The main things OCT measures are retinal nerve fiber layer, RNFL, thickness. This is the layer of nerve wiring that runs from the retina into the optic nerve. Glaucoma causes this layer to thin over time. OCT scans circle the optic nerve and report the RNFL thickness, often as average thickness and in each quadrant. Thinner than normal RNFL can indicate glaucoma damage. Ganglion cell complex, GCC. This is the layer in the macula, central retina, that contains the cell bodies of the retinal ganglion cells, the nerves that carry vision signals to the brain. Since glaucoma kills these cells, doctors also measure the macula's GCC thickness. OCT can show if these cells and their inner synapse layer are thinning. Optic nerve head structure. OCT can image the back of the eye, the optic disc, directly. It measures features like the cup and disc sizes with metrics such as the rim area. A large cup or small rim can be a sign of glaucoma. However, OCT's advantage is mostly its precise thickness measures, not just the cup-disc ratio. Macular central retina. Thickness. Beyond the ganglion cell layer, OCT measures overall macular thickness. Some devices show color maps of the macula. Thinning in parts of the macula may also hint at glaucoma. Progression over time. Critically, OCT allows comparison of scans over months and years. The software can flag statistically significant thinning from one visit to the next. For example, a drop of 4 to 5 microns in average RNFL over a year can suggest real progression. Doctors often use guided progression tools in OCT to see if areas are getting thinner faster than normal aging. Each OCT result comes with color-coded maps and numbers. Green usually means within normal limits, yellow means borderline, and red indicates outside normal limits, thin, compared to a database of healthy eyes of the same age. Importantly, these colors are just estimates. A red area says that part of your retina is thinner than 95% of healthy eyes. It does not by itself confirm glaucoma. It simply flags an unusual finding. Overall, OCT gives doctors precise physical data, how thick or thin the nerve layers are. These numbers let doctors track change more objectively than subjective exams. OCT in suspected pre-glaucoma conditions. Even before glaucoma is officially diagnosed, OCT can be very helpful. This is often called preperimetric glaucoma, where the optic nerve looks suspicious, but standard visual field tests are still normal. In such cases, OCT often picks up early damage. For example, a study of glaucoma suspect patients, those with optic nerves that looked possible for glaucoma, found that the average RNFL thickness on OCT was the best single test to predict who truly had early glaucoma damage. In that study, the average RNFL thickness had an AUC, area under curve, of 0.89 for identifying early damage, higher than any optic nerve photo measurement or macular scan. In practical terms, if your doctor sees a glaucomatous-looking optic nerve, but your field test is still full, OCT can reveal tiny losses of nerve fibers that the field hasn't caught yet. A large multi-center study showed OCT detected progression in almost 60% of such suspect eyes over about 4 or 5 years, while visual field testing only showed progression in 27%. In early mild glaucoma cases, OCT in fact picked up changes in about 63% of eyes, compared to 39% detected by fields. This means OCT is often more sensitive than field tests in the very early stage of disease. However, more sensitive does not mean perfect. A few points to remember. OCT measures anatomy, structure, while visual fields test function, what you can see. Early on, many eyes actually lose nerve fibers before vision loss happens. But not every eye that looks thinner on OCT will go on to get field loss soon. Doctors still watch and use all evidence. Also, some OCT scans can be confounded by other issues. See below. In short, OCT in the suspect stage helps detect or confirm early glaucoma, but it must be interpreted carefully alongside exam findings and risk factors. OCT in early glaucoma. Once glaucoma is diagnosed and is still mild, often called stage 1 or early glaucoma, OCT remains a reliable friend. Doctors use it to monitor whether the nerve layer is thinning further. Because structural loss often leads functional loss, OCT changes will usually appear before the patient notices any field defect. In the early stage, the pattern of loss typically starts in the superior, top, and inferior bottom quadrants of the RNFL, leaving the central vision until later. Several studies confirm that OCT outperforms visual fields in sensitivity early on. For example, an analysis found that OCT flagged new thinning in about 63% of mild glaucoma eyes versus 39% by visual field. In practice, this means if your ophthalmologist sees gradual RNFL thinning on your scans, they will often treat that as true change, even if your field test hasn't clearly worsened yet. This approach is supported by research showing that thinning on OCT currently predicts quicker future field loss. In other words, a small drop in RNFL or ganglion cell thickness is taken seriously because waiting for a field defect might come too late. For reliability, OCT is very precise, but it can have false alarms. Random scan-to-scan fluctuations do happen. That's why doctors look for consistent trends, often requiring 2 or 3 scans before concluding progression. Modern OCT machines often include event and trend analysis, like guided progression analysis, GPA. An event flag might light up if 3 points worsen on 2 consecutive scans. A trend will look at each visit's thickness over time. These must be interpreted with all other information in mind. In early glaucoma, combining OCT trends with risk factors, pressure trends, disc appearance, gives the best guidance on how aggressive treatment should be. Important OCT findings in moderate glaucoma. Moderate glaucoma, stage 2, is when clear field defects are already present, but not yet end stage. Both OCT and visual field changes are typically seen. In this mid-stage, trend monitoring on OCT becomes crucial. Doctors watch for continuing RNFL or ganglion cell layer thinning. A small thin spot in one check may become more obviously thin at the next. Key OCT findings in moderate glaucoma include progressive RNFL thinning. Sustained drop in the average RNFL thickness or in any quadrant is concerning. Studies call a loss of more than 2 millimeters per year in RNFL after baseline, rapid thinning, and a warning sign. This is much faster than natural aging, around 0.3 millimeters per year, so if your OCT shows more than that, your doctor will take notice. New sector losses. If OCT color maps show a new red or very yellow sector that wasn't there before, that indicates a new nerve fiber bundle has thinned. Even if it's small, this is important to recognize. Macular ganglion cell changes. Because moderate glaucoma can begin to affect central vision, doctors also review the macular scans. Thinning of the ganglion cell layer in the macula, shown on the GCC or GCIPL map, can confirm that the damage is real and spreading. Sometimes a subtle macular change on OCT will appear even if peripheral field loss is mild. Correlation with visual field. In moderate glaucoma, OCT changes and field changes may occur together or one after the other. A useful pattern is sometimes called the broken stick model. Early on, a small drop in RNFL may cause little or no field change, but once the nerve is much thinner, small further losses lead to bigger field defects. This means a structural OCT change now could mean a functional field change soon. If OCT shows definite new thinning in moderate glaucoma, doctors usually do not wait for the field to catch up. They will consider escalating treatment, for example, tighter pressure control, because it suggests progression. However, in moderate glaucoma, it is also true that test variability is higher, so often an OCT result is repeated quickly to confirm. If there's any doubt, more frequent monitoring or additional strategies, like 10-2 visual fields focusing on the center, may be used. OCT in advanced and end-stage glaucoma. In advanced glaucoma, stage 3 to 4, where visual fields show large defects or only small islands of sight remain, OCT has important limitations and some remaining uses. The biggest issue is the floor effect. By advanced stages, the RNFL often thins down near the device's measurement limit. Most OCT machines can only measure RNFL thickness down to roughly 40 to 50 microns. Once your RNFL is around that thin, the scan can't reliably tell if it got any thinner. The readings bottom out. In practice, this means if an eye has severe nerve loss, serial OCT scans can start to appear stable even when glaucoma is worsening. The OCT graph just stays flat at the low end. Thus, OCT becomes less useful as a progression detector in very advanced glaucoma because it may miss continuing damage. Visual field tests also become unreliable in this stage. They show high variability on top of already low sensitivity. That said, OCT is not thrown out. There are two advantages left. Macular ganglion cell monitoring. Even if the peripalary RNFL is at floor, the macula often still has measurable ganglion cell tissue above floor. This is because glaucoma tends to spare the very center fovea until very late, so the central macular thickness may still change. OCT scans of the macula, GCC-CL maps, can show progressive thinning when the RNFL can't. In one study, doctors found that the macular ganglion cell complex continued to thin and reveal progression even when RNFL scans were frozen. So for advanced cases, ophthalmologists will often focus OCT on the macula and follow the ganglion cell layer. Asymmetric monitoring. Glaucoma is usually worse in one part of the nerve than another. Even if overall vision is poor, some quadrant or the opposite eye may still have measurable nerve fibers. For example, one advanced glaucoma patient might have lost the lower visual field, but still have normal upper retina fibers. An OCT scan will show that the inferior, top of eye, RNFL is still thick. Doctors track the healthier side as well, because losing that remaining function is critical. In summary, in advanced glaucoma, the standard RNFL scan loses sensitivity due to the floor effect. But OCT can still play a role by checking the central macula and any nerve sections that aren't yet at floor. Also, it can help rule out other problems. For instance, if an OCT scan shows unexpected thinning that doesn't match the disease pattern, the doctor might suspect another eye condition, like macular edema, retinal scarring, etc., of which OCT is also useful. In fact, when vision is very poor, OCT of the macula can spot issues, macular degeneration, diabetic changes, epiretinal membranes, that need treatment to preserve remaining vision. So in advanced glaucoma, OCT use shifts toward protecting what's left, not just measuring glaucoma. Interpreting OCT alongside other tests. It is crucial to remember that OCT is only one test. Glaucoma decisions are never made on OCT scans alone. Rather, an eye specialist will integrate OCT findings with visual field tests. These provide the functional perspective, what you can see. If both OCT and the field show corresponding damage, for instance, a region of thinning on OCT lines up with a field defect, the doctor can be more confident. If OCT is abnormal but fields are still normal, the doctor may watch more closely or do repeat fields. If fields are worse but OCT looks stable, that also triggers caution and possibly a different testing strategy, like using a smaller stimulus size or a central field test. A study even showed that combining OCT and field data finds progression faster than using the field alone. Optic nerve exam. The ophthalmoscope exam looks at the optic nerve head directly. Doctors note the cup-to-disc ratio, rim color, and for nerve hemorrhages, which predict worsening. If OCT flags thinning, but the nerve still looks pink and normal on exam, the doctor may double-check the scan for error. Likewise, if the nerve looks worse but OCT doesn't show new change, potential floor effect or artifact, the doctor may trust the exam more. Intraocular pressure, IOP. High eye pressure is a major risk factor. If OCT suggests progression, for example, drop in RNFL thickness, and the pressure is above the target level, the doctor is likely to treat more aggressively. Conversely, if OCT looks arcane but IOP is always very low and field is stable, the doctor may attribute the OCT finding to something else. Risk factors and clinical context. These include family history of glaucoma, eye injury, heart disease, or use of steroids, as well as demographic factors. For instance, certain ethnic groups naturally have thinner RNFL on average. A scan that's slightly thin might be normal for one ethnicity, but concerning for another. Age is another factor. Older eyes have some normal thinning of RNFL, about 0.2 to 0.5 millimeters per year. The scan software accounts for age when coloring the maps, but doctors still keep this in mind. Guidelines emphasize that no single OCT number confirms or excludes glaucoma. A study noted, for example, that an OCT outside normal Result may still be a false alarm if not confirmed by examination or fields. Likewise, mild visual field loss can occur even with relatively normal scans if the disease is at a stage where OCT is limited. In practice, your doctor will ask, "Do my findings make sense together?" If all tests agree on progression, they will act. If tests conflict, they might repeat testing or choose the most reliable result, often the visual field in advanced disease or OCT in early cases. Common issues that can mislead OCT results. OCT scans are powerful, but they have pitfalls. Several common factors can cause misleading results. Poor scan quality. Blurry images from blinking, poor tear film, or patient movement can skew measurements. If the scan is not well focused or is cut off, the thickness numbers may be wrong. Most machines give a quality score. A low score should alert the doctor to rescan. Cataracts or media opacities. Any cloudiness in the eye, like cataracts or corneal opacities, can weaken the OCT signal. The result is a darker, grainier image and artificially thin-appearing retina layers. Doctors often check whether cataract surgery or additional dilation is needed if OCT results are borderline. Decentration. The scan must be centered on the optic nerve or macula. If the circular scan around the nerve is even slightly off-center, one sector can falsely look thin or thick. OCT software will usually warn if the scan is not centered. In practice, techs carefully align the scan and the doctor reviews the cross-sectional B-scan images to confirm. Software segmentation errors. OCT relies on software to draw lines around each retinal layer. If the algorithm gets confused, it might misdraw the RNFL boundaries. This happens often in eyes with unusual anatomy. For example, high myopia, extreme nearsightedness, or tilted optic discs can throw off segmentation. In a recent study, about 52% of highly myopic eyes had apparent OCT artifacts, and software often misplaced the RNFL edges. This means an eye that truly has a healthy thickness can be mislabeled as thin. Therefore, in very myopic patients, doctors inspect every OCT layer on screen. Coexisting eye conditions. Other retinal diseases can confuse the OCT. For example, an epiretinal membrane, scar tissue on the macula, or diabetic macular edema can change the normal shape of layers. Age-related macular degeneration or previous surgeries can also cause local changes. The OCT might then flag an area red when it's actually a problem from a different disease. Clinicians will check OCT scans to see if the scan images line up or if there is obvious macular pathology. Measurement variability and aging. As noted, OCT values do change slowly with age. Because OCT trend analysis is not fully age-adjusted in most devices, some thinning may just be natural. Also, each OCT machine has its own normal database. If you switch machines, the raw numbers aren't directly comparable. Finally, normal eye-to-eye variation means one healthy eye's RNFL can be naturally thinner by a few microns than the other. Doctors avoid comparing your left eye's map to your right eye's map directly. They compare each to its own age-matched norm. All these factors mean that an OCT report should be reviewed by the doctor, not taken at face value. If something doesn't make sense, e.g. a sudden jump in thickness, the doctor will consider if it could be an artifact and may order a repeat scan. In fact, experts warn OCT results must be reviewed carefully for scan quality and errors. Before concluding glaucoma change, how often to repeat OCT in glaucoma? The ideal interval for OCT scans depends on how advanced the glaucoma is and how fast it seems to change. In general, suspects or very mild glaucoma, if there's only a suspicion and no progression, scans might be done every 12 to 24 months. For example, the European Glaucoma Society recommends initial follow-ups at 6 to 12-month intervals for new cases that are stable. If nothing changes, you might even be sent home longer term. If there are early changes, the doctor will come back more often. Mild to moderate glaucoma. Typically, specialists will do an OCT and exam about every 6 to 12 months. A recent review suggests that twice-yearly OCT is generally sufficient to catch important changes. If an eye is stable for years, some doctors stretch it to annual. But if any risk factor is high, like high pressure, disc hemorrhage, or rapid field loss, they will do scans more frequently, e.g. every 6 months or even 3 months to make timely decisions. Advanced glaucoma. In severe cases where OCT has limited use, floor effect, imaging may be done less often for glaucoma purposes. Some experts say every 6 to 12 months or as part of routine visits. If doctors are instead focused on macular changes or other disease, they might still use that same schedule. However, any hint of new vision loss might trigger an immediate scan to evaluate the cause. In practice, the scan schedule is personalized. Many clinics bundle OCTs with regular visits so that patients get an OCT at each checkup. The key is consistency. Doctors prefer to compare scans done on the same machine under similar conditions. Questions patients should ask about their OCT. OCT reports can be confusing. If your ophthalmologist tells you about an OCT result, here are some appropriate questions to clarify what it means for you. What do these colors, numbers mean? Ask the doctor to explain the report. For instance, if a quadrant of your RNFL map is yellow or red, ask if that is expected or a warning sign in your case. Every eye is different. Is this normal for me? If the report highlights thinning for your age or race group, ask how significant it is. A finding slightly below average might be okay if all other tests, field exam, are normal. Could anything have affected the scan? If your doctor worries about a change, ask if scan quality could be an issue. For example, macula dryness, cataract, or an off-center scan can alter results. Confirm that the scan itself looked clean and that the technician was careful. How does this fit with my other tests? Always see OCT in context. You can say, my vision test was stable, but this OCT is worse. What do we trust? Or vice versa. This prompts the doctor to discuss the full picture. Is there a trend? If it looks like the OCT numbers are getting lower, ask if this is significant progression and whether treatment should be adjusted. If they show you past scans, ask how fast the thinning is per year. What should happen next? Based on the OCT, what do they recommend? Do you need a medication change, surgery, or simply closer monitoring? Should you get another scan soon to double check? Good communication helps you and your doctor make the right plan. Remember that an OCT finding is not a diagnosis on its own. Asking these questions makes sure the OCT results are interpreted carefully in the broader context of your eye health. Conclusion: Optical coherence tomography is a valuable tool in glaucoma care, but it has limits. In early disease and suspects, OCT is often more sensitive than patient-observed vision loss. It provides precise objective measurements of retinal layers like the RNFL and ganglion cell layer. In moderate glaucoma, changes on OCT, especially thinning over time, are important red flags that often precede or accompany visual field loss. However, OCT is never perfect or complete. In advanced glaucoma, the RNFL signal hits a floor, and doctors must rely on other measures like macular scans or vision tests. Throughout all stages, OCT scans should always be correlated with your visual field tests, eye pressure readings, and nerve exams. In plain terms, OCT tells us about nerve thickness changes. It can show damage before you notice it, but it can also be fooled by things like cataracts or abnormal eye shape. As one expert review notes, decisions in glaucoma require combining both structure, OCT, and function, fields, along with other factors for every patient. For patients, the takeaway is that an OCT scan is helpful, but it's not the whole story. Keep asking questions and understanding how it fits with all your tests. Glaucoma care is a team effort between you and your doctor, using all the information available to protect your vision over time. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.